My name is Joy Sertia. My topic is Parial or reverse intravenous antibiotic treatment of endocarditis. Definitions: endocarditis, an endocardial infection that affects internal lining of the valve and cardiac cavities, caused by Streptococcus, Enterococcus faecalis, Staphylococcus aureus, or Staphylococci, and who were being treated with intravenous antibiotic to continue intravenous treatment or to switch to oral antibiotic treatment. Applications in medicine. Patients with infective endocarditis on the left side of the heart are typically treated with intravenously administered antibiotic agents for up to 6 weeks. During the initial phase, intensive care and close monitoring are often needed because the majority of complications, including DAR, are seen during this phase. For a large proportion of patients, the main reason for staying in the hospital after the initial phase is to complete intravenous antibiotic treatment. Therefore, if oral antibiotic treatment might be safe and efficient part of the treatment period for patients in stable condition could take place outside hospital without the need for an intravenous catheter. The oral regimen consists of two antibiotics from different drug classes with different antimicrobial mechanisms of actions and different metabolizations processes to reduce the risk of monotherapy.
Patients with infective endocarditis on the left side of the heart are typically treated with intravenous antibiotic agents for up to 6 weeks. During the initial phase of hospitalization and treatment, patients often require intensive care and close monitoring. After this period, many patients remain hospitalized to complete intravenous antibiotic treatment. In this randomized non-inferiority trial, 400 adults in stable condition who had endocarditis on the left side of the heart caused by Streptococcus, Enterococcus faecalis, Staphylococcus aureus, or coagulase-negative staphylococci, and who were being treated with intravenous antibiotics were randomized to continue intravenous treatment or to switch to oral antibiotic treatment. In all patients, antibiotic treatment was administered intravenously for at least 10 days. The primary outcome was a composite of all-cause mortality, unplanned cardiac surgery, embolic events, or relapse of bacteremia with the primary pathogen, from the time of randomization until 6 months after antibiotic treatment was completed. In the intravenously treated group, the primary outcome occurred in 24 patients, as compared with 18 patients in the orally treated group, with a between-group difference of 3.1 percentage points that met non-inferiority criteria. This trial showed that in medically stable patients who had endocarditis on the left side of the heart, caused by Streptococcus, E. faecalis, S. aureus, or coagulase-negative staphylococci, a transition from intravenously administered to orally administered antibiotics was non-inferior to continued intravenous antibiotic therapy. Full trial results are available at nejm.org.
Pros and cons. Pros. Oral antibiotic treatment could take place outside hospital without the need for an intravenous catheter. Cons. The primary outcome was composite of all-cause mortality, unplanned cardiac surgery, emboli events, or relates or of bacteremia with the primary pathogens. From the time of randomizations until 6 months after antibiotic treatment was complete.
A previous episode of infectious endocarditis is an indication for prophylaxis, but previous rheumatic fever or Kawasaki disease without valvular dysfunction is not. In a patient with a transplanted heart, cardiac valve disease is an indication. Otherwise, acquired valvular dysfunction or bicuspid aortic valve are not. Unrepaired cyanotic congenital heart disease or incompletely repaired congenital heart disease are indications, but simple atrial septal defect, mitral valve prolapse with regurgitation, and hypertrophic cardiomyopathy are not. The presence of prosthetic material is an indication for prophylaxis, while valve repair without prosthetic material is not.
This is Dr. Cal Shipley with a review of endocarditis, cardiac valve vegetations, and stroke. Endocarditis can occur when there is fungal or, more commonly, bacterial infection in the bloodstream, a condition known as septicemia or sepsis. As the organisms travel through the heart, they attach themselves to the valve leaflets between the heart chambers. The oxygen and nutrient-rich environment found in the left side of the heart results in rapid growth of organisms, which form clumps known as vegetations. Unpredictably, the vegetations may detach from the valve leaflets. The vegetations are then ejected into the aorta, where they may travel up into the arteries of the brain, causing obstruction to blood flow and subsequent stroke.
Issue applied in Ecuador. In Ecuador, for the treatment of endocarditis, the intravenous route is preferred because of its maximum efficacy. Commonly used drugs are inhibitors of cell wall synthesis such as heromycin and vancomycin.
Infective endocarditis. It's an infection of the endocardial surface of the heart, which is the innermost layer of the heart. Okay, so we've seen pericarditis, which is the pericardial or the outer sac of the heart inflammation. We've seen myocarditis, which is the main muscle of the heart inflammation. Now we are up to infective endocarditis. So that's the innermost layer of the heart. Now it affects the cardiac valves. Okay, risk factors include prior endocarditis, prosthetic valve, valve disease, cardiac lesions, congenital heart defects, pacemakers, Marfan's syndrome, cardiomyopathy, IV drug abuse, intravascular devices, nosocomial bacteremia. Causes of infective endocarditis include Staph aureus, Streptococcus viridans, fungi, viruses. Let's have a look at that again. So causes include Staph aureus, Streptococcus viridans, fungi, and viruses. Okay. So in acute infective endocarditis, patients have low-grade fever, chills, weakness, malaise, fatigue, anorexia. In subacute infective endocarditis, patients have arthralgias or joint pains, back pain, abdominal discomfort, headache, clubbing of fingers. Okay, so acute versus subacute, these are the features. Clinical symptoms include a new or changing murmur. Now, the most important point or the commonly asked question is this: vascular manifestations. Okay, it includes splinter hemorrhages with TK in conjunctiva, buccal mucosa, palate, and over the ankles, inner bends of elbows, and behind the knee. Diagnosis is history and physical exam, 2 sets of blood cultures. They may have increased white blood cell counts. They may have a murmur. Echocardiogram, ECG, chest X-ray is important to diagnose infective endocarditis. Treatment: they need to be treated promptly as the infection can spread to other parts of the heart and surrounding structures. There's a need for prophylaxis treatment. Antibiotic prophylaxis is needed if the patient is undergoing a surgical procedure or a dental procedure or a GI scope. Now the treatment is accurate identification of the causative agent. Now it's an infection. You identify the agent, give proper antibiotic, and that's how you treat it. But some patients may need prosthetic valve replacement. For fever and pain, patients need aspirin, acetaminophen, or brufen fluids.
Conclusions. In patients with endocarditis on the left side of the heart who were in stable conditions, changing to oral antibiotic treatment was not inferior to continued intravenous antibiotic treatment. Thank you.